Dr. Yushil already here. Dr. Yushil, do you hear me?
Hello. Yes, I hear you. How are you,
How are,
Dr. Al-Juradi?
how are you, Doctor?
Hello,
Okay.
Professor Bishar Ramadan.
Hi, how are you?
Thank you. Thank you. I'm
We
good.
are we are both of us in the same city in Izmir, Turkey.
Oh, you are both colleagues.
Yeah, we are brothers.
Oh, that's good. That's good. Okay. Professor Durgul, Dr. Yushil Durgul, you can start screen sharing just for test to check if there is no any problems.
I have tested.
Can you see my screen now?
Yes.
Yes, yes, that's perfect. That's good. Okay. We should also have Dr. Professor Riyad. He will be moderator for today's session. Let's check. Okay. I'm now contacting Professor Riyad Ahmed Raja. He will be moderator of today's session. When he join, I will do brief introduction, and then he will take the lead and present you, and then we can start with you, Doctor. Okay?
Professor Dorual can also start because he also shared now the
You
presentation.
can also stop. It doesn't.
Yes, you can stop,
Okay.
and after you presented, you can
Okay.
start sharing. Okay. Professor
I
is
just
now
forget.
connecting. He will join any second now. I think everything is perfect.
How many visitors do we have? 22, I guess.
There will be more, I'm sure. Today presentation is very, very interesting, and many of our residents are eager to learn from you.
Zabarak.
I hope from all the audience to mute their microphones so we don't have any interruptions or any noises, please. We should start. We're already 1 minute late, but we should wait for Professor Riyad Ahmed. to join. Let's see.
Our residents also are joining. Dr. Fatih Kapıcı is my resident.
So, Doctor, you are working in Turkey, Izmir, both of you, yes?
Yeah. Do you know Izmir? Have you ever been in Izmir?
No, I
In
never
the-
visited Turkey before. Maybe in the
we
future,
would like to
inshallah.
invite you. We would like to invite you. It's near the Egyptian Sea. So not Egyptian, sorry, Aegean Sea. It's a nice place to live. It's the third biggest city in the Turkey.
Inshallah, I have the opportunity to visit soon, inshallah.
Inshallah.
And you specialize in which branch of neurosurgery? You work
I was
everything, or
a former Rotem fellow. I work with the nuclei and the fiber tracts of functional neurosurgery. But my specialty is the skull-based endoscopic and microscopic skull-based surgery, mostly.
so more in oncology, tumors? Yes?
Yeah. I do neuro-oncology. I try to
So
do not to do other things, but I'm trying to do
yeah, that's good. That's nice. Very
both
nice.
cranial and spinal oncology,
Endoscopic and microsurgery.
endoscopic and microsurgery. Yes.
And Professor Durgul?
I am trying to improve my expertise on oncology also, but I'm in a public hospital, so we always do spine cases and other trauma. But my focus, and I hope my future, I want to be like Professor Bishar. I want to focus more on oncology and vascular surgery.
Here in our country, we don't have such subspecialties in general, but we do all general neurosurgery. We do some microsurgical cases. Endoscopic, we still have some problems with the equipment and the training, but we are trying to learn with the time. We are trying to do. So mostly we do now general neurosurgery and microscopic neurosurgery, spine and cranial. Same. Okay. Let me see if a professor is already in. Otherwise,
It will be nice if Professor L'Oreal can start, because I will also mention that the connection with the insula and the occipital lobe. So it will be better for us if Professor Dr. L'Oreal can start.
okay, that
Okay.
will be good. Yeah.
Assalamu alaikum. I was just having a
Alaikum
problem
salam.
with connection. How are you?
Thank you.
Can
How are
you
you,
introduce
Professor?
me? I'm Dr. Riaz from Pakistan. I'm the president of the Pakistan Society of Neurosurgeons. Can you
How are you,
introduce
Professor
me?
Riaz? Yes, welcome, Professor Riaz. Riaz Ahmed Raja is a consultant neurosurgeon and professor in neurosurgery, and also the president of the Pakistani Society of Neurosurgeons. Professor Riaz will be today moderator of the today's session. So, Professor, I will do a brief welcoming for the audience, and then you can take the lead and introduce the speakers, which we start with Professor Yusuf
So
Dalgor.
just guide me. I have a difficulty little bit spelling the Dr. Yusil Durgal. Am I right?
Yücel Doğruel. It's not.
Yusil
Dorel.
Dorel.
Okay.
Yusil Dorel. And second
Yes.
one, the Hussaini Besar Gulou. Am I right?
It is
Doctor
Hussein
Dr.
Bichar
Hussaini and
Oğlu.
Dr. Yusel. Okay.
Yeah.
So, okay, continue.
So, welcome everyone to the fourth session of the comprehensive neuroanatomy educational course organized by Yemeni Neurosurgical Society in collaboration with the World Federation of Neurosurgery, Young Neurosurgery Forum, and Pakistan Society of Neurosurgeons, along with Neurosurgery Coach and Neurosurgical TV. Today we will have our fourth session, and Professor Riyad Ahmed Raja, Professor of Neurosurgery and President of the Pakistan Society of Neurosurgeons, will be the moderator of today's sessions. So, Professor Riyad, please, you can take lead from now.
So we have the two topics. One is the anatomy of the occipital lobe. First of all, sorry, because I was just in a panic because my computer was not starting and net was not connecting. So first of all, I will welcome all you and also the presenters, Dr. Yusel and Dr. Hussain. And the topics today are the anatomy of the occipital lobe, sulci gara, and the functional region. And second is the anatomy and applied anatomy of the Selyan fissure and the insula. So first of all, we invite Dr. Yusel to present on his topic. So Dr. Yusel, please. And Dr. Yusel is the consultant neurosurgeon in Health Sciences University Tepesik Training and Research Hospital in Izmir, Turkey, where our friend Dr. Mehmet Zilali is also there. So we met in Karachi last week, and he's a very regular person and a very innocent, polite person, and always a very good friend of us.
He is in our university. He is our mentor.
Yeah,
Yes.
he's a very nice person, always very kind. Yeah.
We respect him so much.
Yes. So Dr. Yusel.
Thank you for your kind invitation. Today I will talk about anatomy of the Sylvian fissure and insula. So Sylvian fissure is also known as the lateral sulcus, and it is one of our most commonly used surgical routes. That's why it's so important. And it is the most distinct anatomical structure from the lateral surface of the brain. And in the second part of my presentation, we will talk about the anatomy of the insular cortex, which is a hidden structure, and it's also named as Isle of Rail. We will talk about this anatomical structures and anatomical neighborhood of both these important structures. So from historical perspective, the Sylvian fissure, also known as like I mentioned, lateral sulcus, it is attributed to Francis Sylvius, and this attribution is actually because of engraving by Ward Camp. When you hear in the lower picture, when he published in 1641 his engraving by he attributed the lateral sulcus to Francis Sylvius. But interestingly, actually, the first real depiction of the Sylvian fissure is attributed to Girolamo de Fabrici. in 1600. Also, we should always remember Professor Yaşargil, who was introduced and popularized the trans-Sylvian approach for especially in microneurosurgery and aneurysm surgery. So why Sylvian fissure anatomy is important for us? We use it for vascular lesions, especially for, as I mentioned, aneurysm, almost each kind of aneurysm surgery for the anterior circulation aneurysms and to reach the circle of Willis. There are sometimes arteriovenous malformations around the Sylvian fissure. We use this as a corridor. Also for epilepsy surgery, for selective amygdalohippocampectomy, for insular tumors, paracellular tumors, or even to reach to sometimes to anterior portion of the brainstem. We can use the Sylvian fissure as a corridor. That's why its anatomy is very important for us. From developmental perspective, in the human brain, it can be detected until the 13th week of gestation. So here we can see in the 13th week of gestation, this is a three-dimensional of human fetal MRI, and Sylvian fissure can be detected. And we can, in this picture, in the upper image, we can see its development until the 21st week. So, Sylvian fissure, also named as lateral sulcus, it is the most consistent landmark on the lateral surface of the brain. It is between the frontal, parietal, and temporal lobes. And it has one stem. Anteriorly, it has one anterior horizontal and anterior ascendant branches. Connection of these branches is also called as the anterior Sylvian point. Anterior Sylvian point as an important landmark for us. It divides to Sylvian fissure into two parts: the anterior portion of it, the sphenoidal segment, and posteriorly operculo-insular segment. Also, these two branches, the anterior ascendant and horizontal branches, divides the inferior frontal gyrus into three parts: the orbital, triangular, and opercular gyri. Posteriorly, it has posterior ascending and posterior horizontal branches, and connection of these also called as the posterior Sylvian point. When we look anterior to the Sylvian point, it travels like an oblique route, and medially it reaches through the chiasma and medial portion of the temporal pole. So, in a three-dimensional silicon realistic model, here we can see the medial portion of the Sylvian fissure and its relationships with the uncus and the temporal pole. Also, here now we will see the anterior perforated substance. This is the medial orientation of the Sylvian fissure. In a coronal section, when we look to the Sylvian fissure, it has three clefts. It is a Y-shaped, and when we look to it, it's through the insular cortex, it has two branches. So in this Y shape, it has an opercular cleft which opens to operculum, and this is the real Sylvian fissure. And superior to the insular and inferior to the insular cortex, it has a superior limb of the insular cleft and inferior limb of the insular cleft. From a radiologically, we can see this orientation. I tried to merge these two figures to improve orientation. And this is the opercular cleft, superior and inferior insular clefts of the Sylvian fissure. In Sylvian fissure, as I mentioned, it is the most commonly used, one of the most commonly used surgical routes. And in a cadaveric brain, this is the image of a cadaveric brain from lateral surface, and we see the Sylvian fissure. And superficially, most important structures passes here the branch of the middle cerebral artery and the superior Sylvian veins, also called as the superior middle cerebral veins. These are very important during the splitting the sylvian fissure to not to damage and preserve these structures. So when we look for the arteries, the sylvian fissure has actually all 4 compartments of the middle cerebral artery related with the sylvian fissure. So here we can see a closer up picture, and here more prominent 2 sylvian veins, and we can see the middle cerebral arteries traveling inside the sylvian fissure. This is also, like I mentioned, the cortical branches M4 branches. When they exit the sylvian fissure, they are named the M4. Later, we will also focus on other 3 segments. And here, in a coronal section of cadaveric brain, and the frontal lobes are cut, and as you see here, M1 segment, after the carotid bifurcation, M1 segment of the middle cerebral artery is already it gets into the sylvian fissure. Then around the structure we call the limen insula, it gives its bifurcation and gives the M2 branches. Also, here we can see the in this cadaveric specimen is really good. We can see the middle cerebral vein, also known as the deep sylvian vein. These structures are important during the dissection and opening the sylvian fissure. So when we look to the inferior surface of the sylvian fissure, we are looking from top to the inferior. So it is actually we are looking to the temporal lobe. What are these cortical anatomical structures? Here in the left picture, we can see some transverse gyri. These are transverse temporal gyri, and most prominent one is also known as the Heschel's gyrus, which is related of hearing function. So Heschel's gyrus divides the temporal portion of the sylvian fissure into 2 parts, the planum polare and planum temporale. In the right picture, we can see, as I showed you in coronal section, after internal carotid artery bifurcates and 1 segment goes through the sylvian fissure, and then it goes its bifurcation and branches M2, and then M3 branches. So these branches also known as the sphenoidal, insular, and opercular segments of the middle cerebral arteries. These are completely inside the sylvian fissure. So one other important thing about anatomy of this temporal plane is Heschel's gyrus. It's when we follow its trajectory inside the sylvian fissure, it guides us to the atrium of the lateral ventricle. This is an anterior view of a cadaveric specimen. Here we can see the Heschel's gyrus, and this is planum polare. And the sylvian fissure is in medial side, the superior gyri. There are some between this shallow sulci called as gyri of Schwalbe. And here is the temporal pole. This is a very unique dissection. It is done by one of my colleagues, Professor Demirtas, and his guides, his mentors are Professor Günger and Professor Ture. We are looking at into the sylvian fissure from the medial side. So in this cadaveric specimen, as you see here, we are looking from the medial. There is a window, and all the basal ganglia and insular cortex and thalamus are removed. So we can see the medial, we can see from medial viewpoint the sylvian fissure. So in a closer picture, we can see here frontoparietal opercula, frontoorbital opercula, and temporal opercula. When we specify this gyri, so here is we sylvian fissure, the surface, and we are in the deep side. We are looking from the same window. These are the suborbital gyri, subtriangular gyri, gyrus, subopercular, subprecentral, and subcentral gyrus. And these are the parietal lobe gyri, the posterior, middle, and anterior transverse parietal gyri. Here the transverse temporal gyrus and planum polare. I want to just show one case just about importance of opening the sylvian fissure, and it has some good anatomical landmarks. It is a case of Professor Ture. This is an 18-year-old male patient who has this lesion and presented with hemianopsia actually. And the lesion actually, it's a craniopharyngeal mass and compressing the optic nerve. It has, we usually, if the lesion in the middle side, sometimes we choose more right-handed surgeons choose the right route, but to preserve the already intact optic pathways in this patient, the left-sided approach is chosen. I should say that the left side of the MRI is left side of the patient. This is the visual field of the patient. And this cadaveric image actually shows us from with pterional transsylvian approach, which corridors we can use between the arteries. Classical pterional transsylvian position, 15 degrees head elevated and with rotation to the contralateral side. So dura is open. So the sylvian fissure is opening just behind the anterior sylvian point. Anterior sylvian point is important portion in dissection of the sylvian fissure because the space is larger. Here we can see a deep sylvian vein in this patient. After the dissection, this is the M1 segment or sphenoidal segment of the middle cerebral artery, and here we can see the tumor. This is the ipsilateral already compressed optic nerve. We are cutting the dural fold to release it to not to cause more damage, and if it's possible to preserve, or maybe the functions may come back, already lost functions. So I will pass the resection part, and of course the tumor debulging and removing it. Fusa or dissection. And here we can see it's anatomical, oh, sorry. The M1 segment of the middle cerebral artery, the carotid artery, and anterior cerebral artery. And with a gentle retraction, all this area can be reached in transsylvian approach, and this big tumor can be removed without damaging other structures of the brain. If you don't open the sylvian fissure, we should retract. Here you can see the postoperative result as the brain, and the importance of the opening the sylvian fissure. So my next part of my presentation is about insula. Insula is a hidden cortical structure. It has some functions on sensory processing, emotional regulation, motor control, cognitive functions, and autonomic regulations. And it is like a pyramidal shape structure. It's like reversed weighting standing pyramid. The apex of the pyramid is down and its base is up. And this three-dimensional model shows its some relations of its neighborhood structures, its orientation with the ventricles. Now we will go more deep in its neighborhoods, and it's sulci and gyri. And here, insula, it's inside the Sylvian fissure. It has 5 gyri. These 5 gyri, 3 of them are short gyri, and 2 of them named as long gyri. The short gyri are anterior, middle, and posterior short gyri. Sometimes there are some shallow sulci, and there is an accessory gyrus in these. The posterior 2 parts are anterior long and posterior long gyri. And these, the posterior and anterior, the short and long gyri are divided by the central sulcus of the insula. Central sulcus of the insula divides this short and long gyri. There is anteriorly is precentral and anterior sulcus of the insula, and posteriorly postcentral sulcus of the insula. Here, another view of an insular cortex in a cadaveric specimen. Here, the Heschel's gyrus. So, insula, as I see, it has, as you see, 3 short gyri and 2 long gyri. And this is the central sulcus of the insula. So, connection of all the 5 gyri named as the apex of the insula. And beneath it, there is a limen insula, which is its connection with the basal portions. Insula has 3 sulci around it. These are anterior, superior, and inferior limiting or anterior perinsular, superior perinsular, and inferior perinsular sulcus. So they have 2 different names in the literature. The connection between anterior and superior perinsular sulci, named as the anterior insular point, and between the superior and inferior connection of these 2 sulci is the posterior insular point. This is an angle of view, and this is the inferior limiting sulcus of the insula, or inferior perinsular sulcus. Radiologically, here we can see also the insular cortex in a brain MRI, and this is A, B, C are the anterior, middle, and posterior short gyri. And here we can see the D and E are the anterior and posterior long gyri. Here you can see the central sulcus of the insula. These are prominent landmarks in the MRI. Also, one important thing about the central sulcus of insula, it's usually corresponds to the central sulcus or Rolandic sulcus. So its arterial supply comes from M2 branches of the middle cerebral artery, and also, as I mentioned, the M2 branch and 2 segment of the middle cerebral artery, also named as the insular segment. So here in a cadaveric brain specimen, we are looking superiorly through the insula. The frontal lobe is removed, and here we can see the insular cortex, M2 segments of the middle cerebral artery, and M3 segments, and closer view of this complex vascular anatomy. And from lateral view, here we can see the short and long gyri of insula and their supply M2 branches. And this is one of the unique studies by Professor Ture and Yashargil and El-Mefti. So the branches of the M2 branches of the middle cerebral artery, I want to say that especially the central artery, which goes through the central sulcus of the insula, it is the most prominent artery of the insula. And insular cortex is supplied by these branches by the M2 segments of the middle cerebral artery. And here a very close picture of this. This is the central insular sulcus, and this is the central artery, precentral artery, the posterior short gyrus and anterior long gyrus of the insula. And here you can see these branches are supplying insular cortex, its arterial supply. Also, sometimes branches of superior or inferior trunks sometimes directly can send branches to the insula. So in an analysis, actually, about 85 to 90% of the insular supplier arteries from M2 are short, and they supply the insular cortex and sometimes the structure extreme capsule just beneath the insular cortex. About 10% of these arteries are medium-sized, medium length, and they go through the almost claustrum and external capsule. And about 3 to 5% of these arteries can go deep, and they are named long arteries and almost can go to the corona radiata. In the venous anatomy of the insula, they are named like the central insular vein, posterior and anterior insular vein, and these veins drain into the superficial and deep middle cerebral veins. From the cortical perspective, when we go through deep to the insula, here we can see the insular cortex. Also, I labeled with IC here. There is a white matter beneath it. It's called, like I mentioned, extreme capsule. Then a very thin gray matter layer, claustrum, putamen, claustrum, external capsule, putamen, globus pallidus, internal capsule, and thalamus. This is from lateral to medial, deep insular portions, and now we will see them from laterally. I put this image just for orientation, and when we open the sylvia, when we remove the frontal and temporal operculum and parietal operculum, we can see the insular cortex. So there is a white matter tract which turns behind the insula. It's called also arcuate fasciculus, and its continuity with superior longitudinal fasciculus. These are the superior and posterior relations of the insular cortex. When we remove the insular cortex, there is an U fibers, a white matter tract and U fibers. These are the extreme capsule, which has functions about language processing, cortical connectivity, consciousness, and perception, speech articulation. So when we go deeper, here is the gray matter, the claustrum, and superior to it, its connection with the cortex, the external capsule. Also, again, deep in the insula, there is another white matter tract which connects the frontal and occipital lobes, also called the inferior fronto-occipital fascicle. And there is an uncinate fascicle, it's anterior to the insular cortex. So in a deeper part, here you can see the external capsule fibers, and in the windows you can see the putamen. A deeper dissection, when we remove completely the external capsule, here is the putamen. Here you can see the anterior commissure, and these are anterior commissure and the structure I mentioned in previous slide, the inferior fronto-occipital fascicle. These are all joined here to temporal lobe, also named these dense white matter tract, the sagittal stratum. These are all inferior and lateral to the insula. In a deeper part, here we can see the optic radiation fibers with the putamen. And this shows that it's the temporal horn of the lateral ventricle, just for orientation with the insular cortex. And the final stage, after we remove putamen and globus pallidus, the before thalamus, here is the internal capsule fibers, the ripus part of the insula from lateral to medial. This is an axial section. So here we can see the insular cortex and deeper structures, as I mentioned. And these are very important structures which has many functions like consciousness, sensory integration, motor control support, and various other functions. Thank you.
Thank you so much, Dr. Yusel. And the pics were very good. It was very interesting. And that shows also the clips and the live surgery clips. And that was really motivating for the young neurosurgeons and the senior residents.
Thank you very
Thank
much.
you so much.
Thank
So
you
we
very
have
much
the
for
now
your time.
Dr. Hosseini for his talk on the occipital lobe.
Thank you. I'm sharing the picture now.
Jay.
Can you see the picture?
Not yet, I think.
Or maybe we can. I can thank the WFNS and also great appreciations to Yemeni brothers and sisters and Pakistani brothers and sisters. It's a pleasure to speak here. I guess it is not. Can you see
Assume
now?
that you start. Yes, we can see now.
Okay. I will try to enlarge it, but I cannot do it now. Okay, now I can. Yes. So I'm starting my chronometer for 45 minutes. Because it was an accident, I have to present this presentation 3 or 4 weeks ago. But the technical issues. But I guess that is the fate. That is very important that I am presenting the last, because we have in these modules presented frontal lobe, parietal lobe, temporal lobe, and insula. So now I will explain to you the occipital lobe. But in fact, there is no lobes in the brain. These are cortical and subcortical areas and folds and gyruses and sulci. So I will mention my presentation. I will a little mention about gray matter organization, white matter organization, and now to reach this occipital lobe, because occipital lobe has connections with all the lobes, frontal, parietal, temporal, and deep structures, insula, and also the deep brain structures. So to understand the anatomy of occipital lobe, we have to know all the brain anatomy. So I will mention gray matter, white matter, and try to dissect 4 different ways to reach occipital lobe. These are basal to superior, medial to lateral, anterior to posterior, and some crazy oblique dissections to have a deep understanding of the occipital lobe with the ventricles, the occipital lobe with the central core area, and frontal lobe. So before starting, we have to mention some important areas. Professor Dorel mentioned this Sylvian fissure very well. And this is superior temporal sulcus, middle temporal gyrus, and inferior temporal sulcus. Now, there is a temporal-occipital notch here, which is separating temporal lobe from occipital lobe. There are important gyruses and sulcus. This is the lateral occipital sulcus, superior occipital gyrus, and inferior occipital gyrus from laterally. And medially, there are important areas. The first one, the superior part, is cuneus, and the inferior part is the lingula. And this is the calcarine sulcus, and this is the parieto-occipital sulcus. There are two important sulci, the parieto-occipital sulcus and calcarine sulcus. We will mention it later. So, in the basal part, there are some important structures. This is the uncus. This is the renal sulcus, inferior temporal gyruses, and then near the renal sulcus, it is containing the collateral sulcus. This is the occipitotemporal gyrus, and it's also called fusiform gyrus, and this is the occipitotemporal sulcus. So we have to mention in 3 or 4 minutes the gray matter organization. Unless we don't understand the gray matter organization, we cannot determine the white matter organization. So 5 different gray matter organization. The cortexes are divided into 5 different areas. The limbic areas, the paralimbic areas, the heteromodal association areas, the unimodal association areas, and the primary sensory motor areas. So this is our basic differentiation, the histological differentiation. So the gray areas are the paralimbic areas. The blue is the idiopathic primary areas, and the yellow ones are the modality specific areas. So if you look at the occipital lobe here, the V1 is idiopathic here, and then you see the peristibiate areas we will mention later. And this is the Broca areas. You see the 17th area, 18th and 19th area, and the striate cortex is then it's between 18th and 19th areas. Limbic areas are corticoid areas like septal region, amygdaloid complex, or allocortical areas. These are deep old areas which are hippocampal cortex and the piriform cortex. The paralimbic areas are mesocortex. These are transition zones of allocortical and isocortical areas, orbitofrontal cortex, insula, temporal pole, parahippocampal cortex, and cingulum cortex. Homotypical association cortex are unimodal visual, unimodal auditory, or unimodal sensory. The peristriate area, fusiform area, which is also responsible for determining the face recognition and object recognition area, and the middle temporal region. And the heteromodal association cortex, which are prefrontal cortexes, posterior parietal, lateral temporal, and parahippocampal regions. And of course, the idiotypic cortexes, visual, auditory, somatosensory, and motor regions. Now look at the white matter organization here. Every gyrus has a long association fiber system, a short association fiber system, which are very important in cortical connectivity, and also the not long association but not U fibers, the neighborhood association fibers are very important. The striatal fibers in each gyri, the commissural fibers, the thalamic fibers, the pontine fibers can be seen. And also these connections are not just one dimensional or not just the same strength. These are feedback. There are feedback mechanisms, the unimodal and heteromodal areas send data to the limbic areas and hypothalamus, and also the paralimbic cortexes, and then the sensory motor connection has been done. So where is visual cortex? The information from retina terminates here. The visual cortex is here, V1, V2, V3, V4, V5. And then all the connections here are separated with the fibers, which I will show you later, to the parietal lobe and the frontal lobe, which are responsible for the question where. And also the other part, the temporoparietal language areas, the limbic areas, the temporovisual association areas, which are responsible for what question. Let's look at the areas first before showing deep dissection photos. There are some important areas, the 17th area, the Brodmann 18th and 19th area. Let's look at the 17th area. It's like a strip in the medial part. It's 17, and the most posterior part from the lateral view is 17th area. This is the primary projection for vision. It has a retinotopic map. Up is down, down is up, and surrounded by it surrounds the calcarine fissure, which I mentioned previously. It's largely on medial aspect, like here, and as I said, it's the striate, can be named as striate cortex. Area 18, like here, in the medial part, it was more prominent here. It's a secondary sensory area. It is elaboration and synthesis of visual information, responsible for elaboration and synthesis of visual information. It has many interhemispheric and commissural fibers. I will show the dissections, but just to show that the corpus callosum and the other fiber system going to the 18th area here, connections. It is responsible for orientation, spatial frequency, and color. And now area 19, as we mentioned here, 19th area, Brodmann 19th. It is for, it has a lot of connections, many connections with other regions of hemisphere. It's an integration of visual information with info gathered from other senses, and also visual memory is important. Now, Professor Douriel has mentioned the optic radiations. These Meyer's loop is here, lateral geniculate body, comes through directly to the occipital lobe. This is called the geniculocalcarine tract. It courses deep in temporal lobes, just the lateral wall of the temporal horn, and carries information from lateral geniculate body to the cortex. And visual cortex, as we have previously shown you, it's responsible for what and where visual streams begin. And area 19 is many connections with the other hemispheres. It is a dynamic form, recognition of moving shapes, and it has now no color recognition. Dorsal part and ventral part. Dorsal part goes to the parietal lobe, processing global motion, and ventral part has deep connections with the inferior temporal cortex and fusiform cortex, which is responsible for face recognition and object recognition and tool recognition. So the V4 is responsible for selective color and pattern recognition and has a role in attention. And V5 is in the occipitoparietal junction, and it's mostly important in detection of direction of motion and speed of motion. If we have deficits, damage to V4, you cannot see color, detect color. If you have damage to V5, you cannot detect motion. So let's do, I have 34 minutes. Let's do some dissections. First, let's go to basal to superior. Now, this is the basal part of the brain. The frontal lobe, olfactory nerve, optic chiasm, mammillary body, pons can also be seen. This is the uncus. I have mentioned before, temporal pole, occipital pole. Now, just decorticate the temporobasal and occipitotemporobasal area. Now, after detaching the cortex, we preserve the uncus here. This is the anterior view of that part. You see also the occipital lobe. Now, this temporal pole has been decorticated. This is the uncus here, anterior view. And if you just cut inferiorly the insula, you'll see the uncinate fascicle fibers anteriorly. Now, if you decorticate the U fibers, you will see some connection fibers from occipital lobe to the temporal lobe and to the temporal pole. And inferiorly, these fibers are connecting to the lateral geniculate body. These are some optic radiations, but there are also fibers of the commissural areas and also the other connections, and this is called the sagittal stratum area. But also these are now connecting occipital lobe. Optic radiations here can be seen, as you see from occipital lobe to temporal pole. Now, if you go further dissections in the temporobasal area, you will see a reflection of the ventricle, and some digitations appear here. And also the temporobasal area, you will see the atrium, which is a connection from temporal lobe, parietal lobe, and occipital lobe ventrically. Now, let's extract the U fibers here. You also continue to see the optic radiations. And if you open the ventricle here, just preserving the hippocampus, you see the hippocampus here. And now just open it, you will see the central core area, corpus callosum area, collateral sulcus can also be, and this is hippocampus. This is the head of hippocampus and amygdala. So now we are seeing the temporo-occipital connections with the relation of the ventricles. This is the temporal horn, amygdala, the head of hippocampus, the digitations of hippocampus, and now in the deeper part, you will the thalamus also can be seen. And this is the atrium area. The corpus callosum fibers are here. So just open to understand again, the left visual field comes here. The right visual field separates in the optic chiasm, medially and laterally, comes here, primary visual cortex. As I mentioned before, the optic radiations are called the geniculocalcarine tract, courses in temporal lobes, and carries information from lateral geniculate nucleus to cortex. And if any of these connections, the optic nerve, optic tractus, optic radiations, and also the striate cortex, if any of that part of the these visual system is disturbed, it goes from total blindness to the bitemporal hemianopsia, left homonym hemianopsia, and also the left homonymous hemianopsia can also be seen. So now we concluded our dissections basally. What we have shown, this is the frontal lobe, this is the connection between frontal lobe and temporal lobe. The uncinate fascicle is just here, Limene insula is here. This is the substantia nigra and brainstem. The central core, the diencephalic structures are in the deep area. Hippocampus, amygdala, optic radiations. Maybe we can call these sagittal stratum containing optic radiations. Now, the second dissection is from medial to the lateral dissections. What we will see here, of course, you can see this parieto-occipital fissure and calcarine fissure here, very important structures in the medial part of the occipital lobe, which are separating the occipital lobe from parietal lobe. But in the medial section, we have to see some important structures. The first one, the corpus callosum, is here. In the lateral ventricle, we see corpus callosum, brainstem, the fourth ventricle, and cerebellum. The occipitobasal area and striate cortex, the 17th area of Brodmann, is just here. Now, what we will do is try to decorticate this area stepwise and show the connections of frontal, parietal, and occipital lobes, and also temporal lobes in the medially, so that we can understand where is where. So the close-up view of the corpus callosum, just I want to show the corpus callosum fibers. To show them, just get rid of the ependyma. Now we get rid of the ependyma, and you see the corpus callosum fibers, and this is the gray matter, which is called caudate nuclei. Caudate nuclei has deep connections with parietal lobe, with frontal lobe, and temporal lobe, and also the occipital lobe. It is very important in the habitual motion, and also the emotional aspects of human limbic system. This is the close-up view of corpus callosum, and from occipital to frontal view. Now, what we have done is just get rid of the cortical cortex and show the cingulum bundle underneath the cingulate gyrus. And what we have done is that we dissect this part. The uncus is preserved, and fusiform gyrus can also be seen here. And get rid of all the occipitotemporal region, decorticated that area. Let's look at this part. This is the calcarine sulcus, and this is parieto-occipital sulcus. Now, uncus is preserved here, and temporobasal area, which is fusiform gyrus, is just here. It has deep connections with the occipital lobe. The secondary visual cortex has sending these fibers to show what am I seeing, and the parietal lobe to the parietal lobe, where am I seeing. Now the parietal cortex has been gone, and underneath, if you cut the occipital fibers, there is a connection system between occipital lobe to the temporal lobe, which is called inferior longitudinal fascicles, and the cingulum bundle can also be here underneath, above the corpus callosum, and cingulum bundle also has fibers to the uncus and hippocampus of head of the hippocampus. Now, if you get the hippocampus elevated, corpus caudate nuclei also has a C-shaped variation, and also connected with the amygdala and hippocampus just here. So this is the fibers of the sagittal stratum. Some of them are going into the central core area, and also the cingulate gyrus cingulum bundle can also be seen. Let's look at the connections here. Corpus callosum has deep connections with occipital lobe. You see the corpus callosum fibers going to the occipital lobe, the 18th and 19th areas here, and also the occipital lobe connecting with the temporal pole. So some of the fibers are here. You can see corpus callosum has deep connections in the lateral part of the ventricle. These are called tapetal fibers, tapetum fibers. This is the connection of the corpus callosum and sagittal stratum, which are going to deep into the thalamic pontine fibers, striatal fibers can be seen. So these are the lateral geniculate body and the Meyer's loop also to mention, and the tractography of that optic radiations. And if you preserve the parietal lobe and insula here, and this is the inferior limiting sulcus, which is a part of temporal stem. As you can see, the occipital lobe and the sagittal stratum fibers are going to the temporal lobe. And if you inferiorly dissect, this is the classroom, this is the insula, and these are the Meyer's loop fibers going to the lateral geniculate body. So I will skip these dissections. I want to show you another dissection type. So this is the connection. Now we have studied frontal lobe, temporal lobe, insula, parietal lobe, and now we are trying to adapt the occipital lobe and their connections and their functions. So we have dissected from the basal to the superior and medial to the lateral. Now let's dissect from anterior to the posterior. But to reach that area, I will dissect slowly from frontal lobe to temporal lobe and deep brain structures from temporal lobe and central core to show the connections anterior to the posterior area. Now we are learning anatomy with cross-sectional atlases, and also from surgeries, and also from dissections. But we also use MRI scans. So in order to understand the anatomy of the brain, let's use MRI with the dissections. So let's use cadavers, heads, not just brains, preserve the skull base, scan these cadaver 3 Tesla MRI, preserve skull base, use neuronavigation, and one part from left to the left hemisphere to the anterior to the posterior, and right hemisphere to the lateral to the medial. So in order to understand that the complex anatomy in front of that occipital cortex and occipital lobe, we will give us a 3-dimensional view. This is our head. What we have done with this skull and brain, we decorticated the frontal lobe area, and you see the central sulcus. So why am I showing this? This is not the area of occipital lobe. I'm showing this because I want to show you the fibers, localization of these fibers. And before showing the frontoparietal connections, we cannot show fronto-occipital connections. And 1 minute, just a little quick reminder. There are debates of connections of occipital lobe with frontal lobe. Some authors says there is a superior fronto-occipital connection system, so that in the fronto-occipital area, which is passing from limb and insula, just here is the inferior fronto-occipital fascicle. Some says there is no superior fronto-occipital connection system. There is only one fronto-occipital connection system, which is just passing limb and insula with uncinate fascicle. So I want to mention these connections first. This is the Broca area. All the decortication has been done. Only U fibers of the medial frontal region has been done. So there is a connection system between frontal lobe with the parietal lobe, which is superior longitudinal fascicle system. There is also debate how many superior longitudinal system has been here. Some says 4, some says 3, but underneath this middle frontal region, there is a connection system here. Underneath the middle frontal gyruses, underneath superior frontal gyrus, there is superior longitudinal fascicle system, middle and inferior system is here. What we are mentioning, the frontal occipital connection system, is just underneath these 3 frontoparietal connection systems. And this, you can see the superior longitudinal fascicle system. Now the occipital cortex has been decorticated, and inferior to the occipital cortex, you will see insula, temporal lobe, and also the middle cerebral arteries has been preserved. So, as Professor Doriel has mentioned, to see the insular cortex, let's get a cut here to show the inferior limiting sulcus. We have also a superior limiting sulcus of the insula and the anterior limiting sulcus of the insula. Now we are preserving the right hemisphere, the frontal lobe, all the anterior connections, and the middle cerebral artery to show temporal lobe, occipital lobe, fronto-occipital and frontoparietal connections from anterior to the posterior. What we will see here is the corpus callosum and gyrus rectus. In the deep connection system with the anterior to the posterior, you see the corpus callosum fibers, and there's an ependyma of the frontal horn. Just cutting this ependyma of the frontal horn, you will see the caudate nuclei. And also in the beginning of the gyrus rectus, you will see the anterior olfactory nuclei. Now, we are continuing to show all the connection systems from anterior to the posterior to the frontal, parietal, and temporal to the occipital lobes. What we are seeing here, we are preserving the insular cortex, the superior limiting sulcus, the anterior limiting sulcus, and the inferior limiting sulcus. We have connections of the fronto-parietal connections here. We preserve the cingulate gyrus, and also the callosomarginal and pericallosal arteries are also being preserved. Let's see a deep view of the corpus callosum, and the caudate nucleus also can be seen here. So this is the area which is the merging of the corpus callosum, and all the fibers, internal capsule fibers, are merging and limiting anterior central core, just here. As I want to mention, there is a 60 or 45 degree limiting area of the central core, just here. It is not a perpendicular area. So if you get some corpus callosum fibers retracted, you will see lamina terminalis. Why am I showing lamina terminalis in the occipital lobe presentation? Because you have to understand the third ventricle area and also the atrial area. And to understand that area, you have to go anterior to posterior to the occipital lobe. This is the lamina terminalis, and also the diagonal band of Broca can be seen. Now you see the exact localization of the Broca's diagonal band. Corpus callosum is here. Now we are preserving frontal lobe, and we are opening corpus callosum. We see the both caudate nuclei areas. This part is the septum pellucidum, and also the septile nuclei is just here. To understand more of these ventricular areas, corpus callosum, caudate nuclei is just retracted to show the foramen Monro, and the choroid plexus also can be here. Now, what we have done is just get rid of the ependyma, not destroy anything, just get ependyma, get rid of the ependyma. These are the caudate nuclei, nucleus accumbens, and septal nuclei, and also this internal capsule area. The septal nuclei, and nucleus accumbens, and anterior olfactory nucleus, and internal capsule also can be seen. The internal capsule has digitations. I will pass these parts to show the other structures. But now, in the anterior part of the area, near the anterior part of the third ventricle, you see the anterior commissure, hypothalamic area, and the fornix can also be seen. Now, I will elevate the anterior perforating substance to show the deep connections with the anterior part of the brain with the skull base area, the third nerve, recurrent artery of Höbner, the internal capsule, internal cerebral artery, anterior cerebral artery, middle cerebral artery. The uncus has been retracted to show V1, V2, V3, and petrous carotid artery, and the pons and basilar arteries. Now, this is the occipital lobe here. This is the calcarean sulcus. This is the parieto-occipital sulcus. Now, this is the corpus callosum is cut. The cerebellum is preserved in the left part. The right hemisphere, the right cerebellar cortex is retracted, get rid of. And now the right part of the temporal lobe can also be seen. Now, this is the amygdala, and that part is head of hippocampus. Now, there is a cut in the central core here. Why I did a cut like this? These are not just regular cuts. This is the the localization of the inferior limiting sulcus, and this is just the localization of the superior limiting sulcus. So that this is the part of temporal stem. What is temporal stem? Temporal stem is very important. Professor Roton has mentioned, Professor Yaşalgil and Professor Ture has mentioned that. These are the connection systems of the each occipital lobe, parietal lobe, temporal lobe has connections, the fibers to deep in the thalamic, diencephalic, and deep brain brainstem connections has passed this area. So this is a very important area. This part is the amygdala here, and head of hippocampus is here. These also has, I have mentioned the connections of this area with the occipital lobe. Also in the basal area, there is a fusiform gyrus, which I now cut here to show you the connection systems between the brainstem and that mesial temporal areas. So if you are dealing this part here, for example, in the superior tentorial infraoccipital approach, there is a risk of that these brainstem structures and the temporobasal structures can be damaged. So there are fibers of this amygdala, which is also, I have to mention that amygdala has an extended amygdala merging into the deep brain structures. There are amygdala fugal and amygdala pedal pathways. And also this is hippocampus head. Now it's more posterior to anterior view to show pineal region and superior and inferior colliculi, posterior cerebellar artery, and perforating thalamoperforating arteries with supplying pulvinar, and that part is the internal capsule area. So if you cut the internal capsule area halfway, now there is globus pallidus externa and interna. Now we are trying to show you the connections of this third ventricle area and also the corpus callosum area to show you that occipital, parietal, and temporal region connections. These are more anterior to posterior views. Anterior commissure is preserved in both parties. This is lamina terminalis, diagonal band of Broca is here, optic chiasm, anterior communicating complex, internal carotid artery, third nerve, anterior clinoid process can also be shown. Now, let's go further dissections to show you the third ventricular area. Now, if you preserve the right-sided third ventricle wall, there is an ependyma, and just near the ependyma, this is subthalamic nuclei and red nuclei. Anterior commissure, fornix, foramen Monro are preserved. This is the mammalothalamic tractus. So these are also the anterior coronal, sagittal, and axial view of the subthalamic nuclei. Now we are showing now, this is the parieto-occipital cortex, as I mentioned. This is corpus callosum, this is cerebellum, and this is occipital lobe. Now anterior to the occipital lobe, the third ventricle is now opened. Adhesio interthalamica, pineal region, are now preserved. This is the fourth nerve. This is the third nerve. Mammillothalamic tractus, fornix, anterior commissurius cut. Now, we are looking at from anterior to the posterior. Occipital lobe is here. The connections of that area also is, this part is the posterior commissure, aqueduct, base of the third ventricle, red nuclei, subthalamic nuclei, substantia nigra, and lateral geniculate body is here, which all the occipital lobe fibers, the connections of the Meyer's loop are attached. And anteriorly, anterior commissure, foramen Monro, is preserved. So this is more close-up view of that area. I'm skipping these areas. So this is the mammillary body here, pituitary stalk, optic chiasm is cut, optic tractus is cut. So this lateral geniculate body is connected, these fibers goes directly here, and then occipital lobe. But between these visual system fibers, there are a lot of important nuclei and neurovascular structures. So this is the anterior view. Now also can be seen occipital lobe, calcarine sulcus, parieto-occipital lobe. Then that part is the atrium, which also has deep connections with the occipital lobe. Now I want to show some pictures of the corridors, this surgical corridors. This is the superior occipital, infra occipital, superior cerebellar way to go to the occipital lobe and also the mesial temporal lobe. There is a deep neurovascular structures as we have to preserve, and this part is this pineal region. Now, calcarine sulcus, as we open the calcarine sulcus here, corpus callosum is here, temporobasal area is here, occipital lobe is here. The parieto-occipital lobe, sulcus, and calcarine sulcus are retracted to show the connections of that vascular supply and deep venous drainage. Now, if you have an interhemispheric approach to go directly to the atrium, let's go and see what we are showing. This is the atrial area. This is the periatrial region. Medially, we can have access that region so that anything from here, from parietal occipital connection here can be accessible. And also you can use the transgyral approach to reach that area, corpus callosum and their connections. So I have been, I want to show some, this is the surgical anatomy of spine, head, neck, and brain neurosurgical anatomy. This is the neurosurgical board preparation book, 1,000 paper. And this is the surgical anatomy of function, 2,300 pages we have been published. And pain surgery, spastic surgery, surgery of the regions, functional organizations, cranial nerve and peripheral nerve functions, basic neurologic and psychiatric diseases, epilepsy surgery, diseases of motion, psychosurgery, gray matter and white matter. And I want to thank to Professor Roton, rest in peace. We have been working with all the Roton Fellows for about 14 years now. I had hair that days, and we have been done the first, second, and third International Roton Society meeting, and fourth this year in Taiwan. Professor always said, keep working hard, not just keep working hard. So thank you very much for listening me. I have finished my presentation. I guess my sharing is stopped.
Thank you so much, Dr.
Hussein.
Dr. Hussaini. Yes, Hussain. The last words I much appreciate that you said repeatedly that the not only the work, but the work hard, repeatedly work hard. That's a very good verse and for the inspirational postgraduate students also. So a very nice presentation of the complete overview of the occipital lobe, the supracerebellar transcortical approaches. So over to Gemini Neurosurgical Society. Can we have an question answer session here?
Yes, we can do. If there is anyone have any
Yes.
questions or any
Okay.
comments,
So anyone who
to
have
speakers.
any query, question and answer. So what is the time period for the question answer session?
I guess we have time.
Can have
Yeah.
yes, we have some time, no problem.
So can I over to you, Mr. Your good name?
Yes, Dr. Ahmed
Yeah.
Jiradi.
Yeah. So continue for the question answer session.
First, thank to Dr. Ujil Durul and Dr. Hussein for this very amazing presentations and very nice the sections and the pictures. We learned a lot today, and there is a lot of information. I will see if there is anyone of the audience. Please, if anyone have any question, please you can write in the chat, or also you can ask directly if you want. So I'm looking for the chat now, see if there is any questions. There's only thanks and compliments for the speakers for this nice
I
lecture.
think there is no any question right now. So over to you.
The presentation was very clear, very thorough, and was very nice. I don't see any questions here. And as Dr. Kotos Al-Mansoub also said that it was very clear presentations. So I think by this we can conclude our first sessions. What do you
Dr.
think,
Salman Sharif
Professor?
is Dr. Salman Sharif is regular, and he told me, but just because of the problem of the time, so I couldn't manage it. But today I really appreciate, and I really enjoyed, and at that time I was just message to my PSN group, Pakistan Society of Neurosurgeons, that the lectures is very fantastic, and they are really type of the lectures where young neurosurgeons and the trainees should get more information, because these are not only the purely an anatomy, but anatomy combined with the approaches and also the clear movies of the pics of the surgery. So this is a really a good chance for the trainees to join us. And for the future, I will recommend all the trainees and the young neurosurgeons. This is a very good medium of having a knowledge regarding the all the approaches. And so thank you so much.
Thank you, Professor, for your nice words and nice comments. And this module is really is targeting mainly the young residents and medical students who are interested in neurosurgery, and but also has some nice information that even senior neurosurgeons can learn from. I learned a lot from my side. So thank you very much, Professor Riaz, for moderating this session, and thank you, Dr. Eugene Dorel, for this nice presentation,
Thank you
and Dr. Hussein.
For the kind invitation. Thank you so much.
We were honored by
Thank
your
you.
presentation, and thank you, Dr. Dr.
Thank you.
Hussein, for your very fantastic presentation. I think by this we can conclude our first sessions. Dr. Riaz, Professor, you have any last word or any closing words?
Because inshallah, we have next time maybe a moderator or maybe someone else, but really we will join and take a time to learn from these Zoom meetings.
Thank you.
Thank you very much.
Thank you so
so
much.
this-
Thank you, Dr. Hosseini and Dr. Yosef. Thank you so much.
Goodbye.
Thank you, everyone. And by this, we can conclude our first sessions. And as always, we will have a session every Friday at same times. with more speakers and more presentations. And I hope from all the audience to join and to enrich the discussions and to prepare if they have some questions, because questions and the discussion is really is more enriching the presentations. What do you think, Doctor?
Yes, of course.
Thank you, everyone, and thanks for attending. And by this we can conclude.
See you.
So
Goodbye.
goodbye, everyone, and see you next Friday, inshallah.